Welcome to EmCyte's webinar series. Join us as we explore the latest clinical insights and the science behind precision biologics.
We'll have two presenters, Dr. Mary Ambach and Dr. Sina Farzaneh. Dr. Ambach will give us the clinical perspective, and Dr. Farzaneh will give us scientific rationale behind PRP formulation choices. Um, so uh, the format remains the same. We'll do two presentations and we'll follow up with a question and answer series at the end where please feel free, don't hesitate to ask as many questions as possible, share your insights and your comments, and then we will end with a brief note for announcements and we'll close off with that. So I'll go ahead and introduce our first speaker, Dr. Mary Ambach. So for this evening's webinar, she's joining us from California. She's a nationally recognized physician who holds double board certifications in PMR and pain medicine, along with dual fellowship training in orthopedic sports and spine medicine and orthobiologic and regenerative medicine. Dr. Ambach is the founder of BioEvolve, San Diego Orthobiologics and Sports Center, where she provides cutting-edge orthopedic regenerative treatments. She has more than 2 decades of clinical experience. She is widely respected for top-tier treatment of sports injuries, spine conditions, and joint disorders. Now, in addition to her clinical expertise, Dr. Ambach is deeply committed to education and advancing the field of regenerative medicine. She's a clinical instructor and voluntary assistant clinical professor at the UC San Diego School of Medicine and the Department of Orthopedic Surgery. She is well published with multiple peer-reviewed publications and has made substantial contributions to medical journals and textbooks. As a leader in orthobiologics, Dr. Ambach has trained and mentored physicians all around the world on advanced autologous cell therapies. She currently serves as president-elect of the Interventional Orthobiologics Foundation, IOF, and is a co-founder of Women Physicians in Orthobiologics and Wellness. Dr. Ambach has numerous honors and awards, including being a multi-time recipient of the San Diego Top Doctor Award. Her accolades underscore her leadership and commitment to research and clinical excellence. It is my honor to welcome Dr. Ambach. So it goes without saying that we are thrilled to have you, Dr. Ambach, and we're looking forward to your insights. I will not delay any further, and I'll hand over to you now.
Thank you, Natalie. I'm going to share my screen. Can everybody see that okay? Perfect. Good evening, everybody. Thank you for joining us. I'm Mary Ambach. This evening, I will be speaking about the use of platelet-rich plasma for low back pain, the clinical indications, the rationale, and the technique. So for those of us who are using orthobiologics for spine pain, majority of our patients seek us because they failed multiple standard treatment options to provide pain relief for their chronic spine condition. They want to search for a natural and non-surgical means to heal their injuries, and they're excited about the possibility or the potential to restore and repair tissue injury. These are the potential mechanisms of how platelet-rich plasma can help low back pain. Mainly, it's due to its effect on helping tissue proliferation, modulate inflammation, and on its analgesic effects. I'm not going to go over this in detail. These are well documented in published literature, but I have it here for your reference. So we're going to briefly go over some of the RCTs that are relevant to our discussion tonight. We're not going to be discussing intradiscal injections tonight, which is probably one of the ones that has the most data to support its use using biologics. And aside from discs, epidural PRP is probably the second most that has published data on in the support of its use. This is the first RCT on comparing epidural PRP versus epidural steroid injection for chronic low back pain and radiculopathy. They enrolled 50 patients, followed them up for 6 months, and they had a caudal epidural approach using leukocyte-rich PRP versus Celestone steroids. And it was a total of about 16 ml of volume of the injectate. If you look at your graph on the right side, the red line is the PRP group and the blue line is the steroid group. And as you can see, the steroid group did better at 1 month for their pain relief. However, after 1 month, the steroid group continued to decline in its effect and the PRP group started to feel better. So the results at 6 months showed that the pain score and the short form survey, which is the functional outcome measure, was better in the PRP group at their 6-month follow-up compared to the steroid group. This is another RCT, this time comparing steroid and PRP, but this time using a transforaminal epidural approach. So they enrolled 42 patients, again, a 6-month follow-up. They used a PRP that was 3 to 5 times baseline. So it was about 2.25 billion platelets per foramen. It was a 3 ml volume injection per foramen. And if you look at your graph on the bottom left, you're seeing the same pattern wherein the steroid group did better in the first month, but then the PRP group was the one that continued to have longer lasting effects and continued on its decline for the pain score, with the mean numeric rating of 1.43 for the PRP group versus 5.43 for the steroid group. The PRP group also had a better global perceived effect compared to the steroid group. There's 4 more randomized controlled clinical trials comparing epidural PRP versus epidural steroid for lumbar radiculopathy, lumbar disc herniation causing low back pain, and these are all favorable towards PRP. And to sum up all these 4 studies, they enrolled anywhere from 30 to a little more than 100 patients, about 6 to 12 months follow-up. And the same trend has been shown wherein the steroid did better for the first few months, but then there was a consistent decline in the steroid effects after the first couple months. And the PRP offered a superior and a more sustained benefit up to the 6 to 12 month follow-up period. For facet joints, there's not much data like the epidural. There's 2 RCTs that has been published comparing facet joint PRP versus facet joint steroid injection. The first study was published by Wu, and they compared PRP versus lidocaine plus steroid injection intraarticularly to the facets. They enrolled 46 participants, follow-up for 6 months. They injected 0.5 cc of volume of PRP that was about 4 to 5 times in concentration than baseline. And their results showed that the PRP group did better and had sustained improvement over the follow-up period of 6 months. And the same pattern wherein during the first month, they both had the same results or the same improvement in their pain score and their functional outcome measures in terms of the ODI and Oswestry Disability Index and the Roland-Morris Disability Questionnaire. The second RCT is similar in that they also compared steroid versus PRP, and it was also a 6-month follow-up period. They enrolled 50 patients, and these patients had a confirmed facet joint pain with 2 diagnostic blocks that were positive for facet joint. And if you look at your graphs on the bottom left, the red line is the PRP group. The first graph on the left has the percentage of the participants on the y-axis, and in the x-axis was showing the decrease in, the months, but was showing the decrease in pain that was greater than 50%, while the graph on the right was showing the improvement in the Oswestry Disability Index, which is a functional outcome measure. And so similarly, you can see that at the first few months, the steroid group did better. It was showing the same pattern wherein the steroid group had better improvement at the first couple months. They had similar improvement at 3 months. But then after the 3-month period, you can see that the red line increased, which means there was a higher percentage of participants that had better improvement of their pain score, more than 50% improved, and of their ODI scores. For SI joint, there's one RCT comparing steroids versus a PRP. It was 40 patients that were enrolled. They injected 3 ml of EmCyte poor PRP formulation, and they found that at 3 months, the steroid group had a 25% reduction in the pain compared to 90% with the PRP group. And the PRP, as you can see, had a more sustained improvement in their SF short form survey 36, which is a functional outcome measure, and the modified Oswestry disability questionnaire at 1 month. So ever since the introduction of orthobiologics for spine pain, there has been a renewed interest in the concept of the functional spine unit. The chronic low back pain, being a complex condition, usually has multiple pain generators. And so the paradigm has shifted towards treating the whole functional spine unit, meaning including all the structures that can contribute to the symptom and to the instability of the spine, and treating all those structures for better functional outcome improvement. And so we tested this hypothesis, and we published the first study to use a personalized treatment of multi-target injection in the low back. And this was a prospective case series of 46 patients. We injected the facet joints, the intervertebral discs, epidural space, and the paravertebral muscles. And we use an established clinical criteria that includes both clinical symptoms, physical exam, and imaging studies to determine the structural targets. We followed these patients for 1 year, and we found statistically significant improvements in the patients' VAS or pain score and their functional outcome measures up to the 1-year follow-up compared to baseline. There was almost 70% reduction in the number of patients that were taking opioids. Patients were satisfied, and 82% of them would repeat the injection if need be. And using this approach, there was no reported serious adverse events that we found. And so just to summarize the RCTs that are now available, excluding the discs, there's 6 RCTs on PRP epidurally showing favorable outcome. There's 2 RCTs on using PRP for the facet joint, 1 for the SI joint, and 1 RCT using a multi-target injection. And this was a comparison of prolotherapy versus PRP. There's 1 non-favorable outcome by Sue, but this was a very small volume blood draw, 18 ml, and the injection was ultrasound guided. So those might have contributed to the outcome of the study. For those of you who are doing this, there's obviously some limitations of the functional spine unit approach. First of all, it can be time consuming, especially if you're doing multiple level injections. You can easily get to at least 10 injections per session. There's no validated and established criteria for the selection of structural targets. And these are all based on basically patients' clinical experience, clinical acumen, on identifying pain generators and knowing their patients' functional outcome and ability to do certain tasks. And there's very limited published research on this approach as well. But this, I think, personally, I believe is where the future is going with regards to using orthobiologics for spine, is a functional spine unit approach using multi-target injections. So for our clinical case today, we videoed a case using a multi-target injection. This is a 76-year-old retired male, moderately active, who have chronic low back pain with radiculopathy. He had L4-5 bilateral moderate neurofemoral stenosis. He's got facet arthritis. He's got 4 millimeter central disc herniation. So basically, the most common clinical picture that we see for our chronic spine patients. He had the clinical presentation that was consistent with radiculopathy, and also clinical presentation that was consistent with facet joint pain with positive facet blocks. And in the setting of facet arthritis, spondylolisthesis, scoliosis, he also had the clinical presentation that was consistent with an SI joint pain and SI joint dysfunction with positive response to prior steroid injections into the SI joint. He didn't have any symptoms that are consistent with the discogenic kind of pain. So I went ahead and planned to do an injection of the epidural space, basically a transforaminal epidural injection at L4-5, also including the facet joints in that area, and also perform an SI joint injection on the same session. So we did a 120 ml blood draw. And for the sake of the discussion, I'm going to use the terms leukocyte poor and leukocyte rich formulation, although as we know, these are basically archaic terms now for describing the kind of formulations for PRP that we have. And Dr. Sina will describe this in more detail in the next presentation. But I did the first 60 cc of whole blood was made to produce a 6 cc of a less inflammatory kind of PRP with less leukocytes. And this was used for my transforaminal epidural injection. It was a 3 cc injection to each foramen, so a total of 6 cc. I didn't really want to inflame his already radicular symptoms. And then for the other 60 cc whole blood, this was used to produce a 6 cc of a more of a multicellular, more leukocyte favorable PRP formulation. And I used this for the joints. I did 1 cc injection to each facet joint in the L4-5 region and 2 cc into the SI joint region. And I used the remaining PPP, platelet poor plasma, about 1.5 cc to the interspinal ligament at the same level. And I used the rest of the PPP, about 2 to 3 cc to each side SI joint ligamentous complex. So the baseline platelets for this patient was 150,000 per microliter. The platelets in the PRP was 1 billion per ml, so we were able to concentrate it to about 7.5 times baseline concentration. So let me make sure that I can adjust this. Okay, so let me pause this for a minute. Okay, so this is about a 6-minute video of the injections that we did, and I'm going to try to talk over them and pause to point out certain things. So the first injection is the epidural injection transforaminally in the L4 area. And you're going to see the left L4 epidural region. Sorry, I don't know how to, there you go. Okay, so you're going to see the left L4 area here that's being injected. We started in the oblique region. Sorry, I'm having difficulty with my videos here. You saw me do a lidocaine injection in the skin and subcutaneous tissue, and I basically use a inferior subpedicular approach, superior supraneural approach. And once I was close to or touched the periosteum or the os, I switched to the AP view to see where I am in terms of the pedicle. We definitely don't want to go past that 6 o'clock line so that we don't go too far medially. As you can see, there were some osteophytes here that I was trying to maneuver to, and I was trying to get away from the osteophytes. And so this is the lateral view. And the lateral view actually is showing the needle. And I'm trying to pause this, sorry, and it doesn't let me pause. So it's showing the needle in the superior portion of the foramen, and you want this in the superior portion so that you're away from the nerve roots. And you can also see that it's posterior to vertebral body so that you're away from the vascular structures. And in the AP view, this is still a little bit more lateral. And I wanted to check if there was any vascularity in that area. And if you look at the dye contrast, some of it were spilling at first. And so I had to adjust it to go a little bit more medially to show the contrast pattern to go in the midline section. So one thing that I wanted to point out when you're using orthobiologics for the spine is that because we don't know the actual effect of the contrast on the platelets and the growth factors, you want to use as little amount of contrast as possible. And so as long as you're satisfied with the contrast, you don't have to inject as much. Like for this foramen, I was probably only injecting 0.2, 0.3 ml of volume. And then once I was satisfied that there was outlining the nerve root sleeve medial to the pedicle, I went ahead to inject the PRP, obviously non-vascular flow there. I went ahead to inject the PRP, and 3 ml was injected into that, into each foramen. And I did the same thing into the to the right L4 area as well. So now let's go on to the facet joint. I injected each facet joint L4 into each side. And as you can see, you can barely make out the facet joint here because it's really arthritic. I started with the left L4-5. This was an oblique view. And after local anesthesia, I used a 22 gauge 3.5-inch needle to get into the facet joint. You can go either into the inferior capsular recess or superior capsular recess, or midline into the joint, whichever your needle and the structures will allow you to do. And then once you're positioned, you can check your view in the AP view to see if you are next to the facet joint or to midline. And this is also where you would want to check the contrast to see if you got a good capsular pattern. So I'm, again, same as the epidural, because the facets can only take, very small volume of injectate, usually 1 ml in a normal facet and 0.5 to 0.75 in a very arthritic facet. You want to inject probably about 0.1, maybe 0.2 ml of that contrast. Once you see that capsular pattern, you don't really need to inject too much. And so in the AP view, you can see that nice pattern of the facet joint capsule. And I was satisfied with that, so went ahead and took out the contrast and put the PRP injection. So with this facet, I was able to inject 0.75 cc of PRP into the intraarticularly, and then the other 0.25 I peppered around the capsule of the facet joint. And did the same thing on the other side. This is now the right L4-5 facet joint. And again, it started with the oblique view. Once I was satisfied, I checked with the contrast. And you can see the nice capsular pattern, intraarticular pattern of the dye here. And again, just 0.1, 0.2 cc of a contrast injection, and then went ahead to inject the PRP after that. Next thing that I did is to do an interspinal and supraspinal ligament injection. With this injection, you can either do this using fluoroscopy or using ultrasound, wherein you can actually see the ligaments really nicely. So if you are using fluoroscopy, you're going to start in the AP view and you want to make sure that you are midline. I just wanted to point out that the red blood tinge here in the syringe that you can see is not a vascular blood, but that was from the prior PRP from the previous injection. And so once you're satisfied that you are midline within your interspinous process, you can go lateral, and that's really where you're going to adjust the depth of the injectate. You can use a 25 gauge, but in my experience, it's really hard to inject, especially with the 3.5 inch needles, very hard to inject through the ligaments using a 25 gauge. So I typically use a 22 gauge for the ligamentous structures, and basically most of my procedures in the spine. So now you can see the needle just passing through that supraspinous ligaments between L4 and L5. This is the time that you're going to tell patients you might feel a little pressure, because for the ligamentous injections, these patients can feel this a little bit more. And so I was just going very, very slowly, passing through the interspinous ligaments, and you can go as deep as um, as deep as you can go, obviously not going to the epidural space. No contrast is needed. What I use here was a platelet poor plasma injection into the interspinous ligaments, and what I did was inject the PPP, and then on my way out, slowly inject more small aliquots until I was the supraspinous ligaments, and then when I was at the supraspinous ligaments, just kind of pepper it on top of L4 and on top of the L5 spinous process to cover these ligamentous structures as well. Okay, so the last procedure would be the SI joint. Again, the standard of care for SI joint is using fluoroscopy, although you can use ultrasound for this in leaner patients. Just know that if you're using ultrasound and you're going to the superior part of the SI joint, this is the fibrocartilaginous portion of the SI joint. So you kind of have to dig in a little deeper just to get into the joint. The traditional approach is to go through the synovial portion of the joint, which is the inferior part of the SI joint. And so the fluoroscopy is positioned cephalad and either ipsilateral or contralateral view to show the different outline of the SI joint. So the medial lucency here is the posterior joint. So that's your target. The lateral outline here is the anterior portion of the SI joint. So once I was satisfied with the needle tip in the medial lucency, we then go into the lateral view to check the depth and to make sure that the needle tip is in the area where the SI joint territory is. This is probably a little bit more superficial and too early for me to check the dye. And you'll see the initial pattern is more of a soft tissue pattern here, right about there. And so I adjusted the needle a little bit deeper to get to the SI joint territory. And once I saw a little bit of that capsular pattern into the inferior SI joint, I stopped. Again, same principle, where you don't really want to inject too much into these joints. You want to fill the joints with the biologic rather than the contrast. And so with the AP view, it showed me the inferior portion of the SI joint there. And once I saw that, I was satisfied and was ready to inject. It's very hard to get an SI joint arthrogram, as a lot of you can probably relate. And you don't really want to get a full arthrogram picture here, because your goal is really to inject the biologic. And so I was able to inject 2 cc of the PRP intraarticularly. And what you can see here is on my way out, I was peppering some of that PRP into the dorsal inferior SI joint ligamentous complex, and use PPP for the inferior ligaments. And then I did the same thing into the superior dorsal SI ligaments and into the iliolumbar ligaments. You can also use a dye here to confirm, especially in the iliolumbar ligaments, that you are ligamentous. Or you can use an ultrasound, which can actually show you the ligaments better than fluoroscopy. And you can also include the sacrotuberous and sacrospinous ligaments in your whole SI ligamentous complex here. So this was PPP being injected, making sure that you are in the cortical area and not into the peritoneum. Okay, so take-home points. Biologic treatments to the spine will need a personalized whole functional spine unit approach. There is now increasing evidence of good quality data. I think the last systematic review had level 2 evidence for PRP for low back pain, but there is now increasing good quality data on its safety and efficacy for PRP use for the discs, the epidural space, facet joint, and SI joint. And we need more high quality studies along with real world evidence to move the orthobiologics field forward, especially for spine pain. Thank you very much. These are my contact information. Feel free to contact me if you have any more questions.
Thank you so much, Dr. Ombach. That was wonderful. So we're going to move into our second presentation now. We're going to switch gears to Dr. Sina Farzaneh. So our next speaker, many of you know, he's the scientific director of EmCyte Corp and our resident expert in tissue engineering and regenerative medicine. Dr. Farzaneh has been diligently doing his part to advance the research in regenerative therapies and to addressing knowledge gaps in treatment protocols and biologic compositions and formulations. He has researched and studied the molecular biology of wound healing, and he has done tremendous work in the design and the development of smart biomaterials, and which in his work has a continued influence on new biomaterial designs. He's a highly published author. He has many peer-reviewed publications in tissue engineering, biomaterials, and drug delivery. And he also serves as a peer reviewer for journals such as Stem Cell Reviews and Reports. Dr. Farzaneh's expertise in materials engineering and his biomedical background have created a really unique and brilliant foundation. He has a wonderfully innovative approach and way of thinking, and he has certainly aimed all of that with full force at dissecting and understanding the pathways and mechanisms involved in regenerative biologics. With that said, I'm sure we're all excited to hear Dr. Farzaneh's insights, and I'll hand over to you, Sina, now.
Thank you so much, Natalie. Can you see my screen, everybody? Oh, perfect. So hello, everyone. Welcome to Regenerative Edge, our webinar. So monthly webinar tonight. I walked through the PRP bioformulation for lumbar spine injection. The goal is to connect the biology of what in a PRP and why bioformulation matters, especially when we are close to sensitive neural tissue. I'll start with the broader orthobiologics landscape and then PRP preparation and type, then the immunology, monocyte, macrophage, lymphocyte, and finish with the key evidence and practical takeaways. Thank you so much, Dr. Ambach. Thank you so much, Natalie. So let's start with a brief introduction on the orthobiologics. Let's anchor PRP inside the larger orthobiologics toolbox. Orthobiologics are a biologic substance used to support musculoskeletal healing. Things like PRP, bone marrow aspirate concentrate, microfat, nanofat, concentrate proteins, and hyaluronic acid. Among all available regenerative biologics, PRP is the first line regenerative biologics and one of the most acceptable option because it is autologous, quick to prepare, and can be tuned at least somewhat by how we process and collect it. So PRP actually is made from the blood, and based on the cell-centric vision, we have a different cell in the blood, and the purpose for PRP preparation is when we draw the blood using the centrifugation technique or something like that, or other available techniques, remove the red blood cells as much as possible and enrich the plasma by platelets. However, we have other cellular component in the blood, including different lymphocytes, monocyte, neutrophil, basophil, eosinophil, and we can include or exclude them the bioformulation depending on the bioformulation we want. But as the main player of the PRP, the platelet has a cue role upon the activation of the platelet and degranulation of the platelet. It produces and releases so many different cytokines, growth factors, and you're familiar with them. But the most important things is PRP's function. It can provide and it can actually, it gives us two main function, regenerative function or anti-inflammatory function. And the first question when we are going to use the PRP is what function of the PRP mainly we are gonna use that for our treatment, for our indication. Do we want regeneration? Do we want inflammation? Both of them? Which one more? And based on that, we can decide which bioformulation would be the best bioformulation for us. So as we discussed in over our previous webinars, since EmCyte introduced recently the Aspiradon technology as the double spin system PRP preparation, it actually provides the flexibility to make different bioformulation. We can easily make leukocyte poor bioformulation, we can make monocyte rich bioformulation, we can make neutrophil rich bioformulation. As Dr. Ambach mentioned, leukocyte rich, actually the leukocyte rich bioformulation she used was the monocyte rich. I was there, I had that opportunity to be with Dr. Ambach on that day, and we actually made the monocyte rich for two indications, and for one indication we use the leukocyte poor. As you can see in this picture, after the first spin, when we take the Buffy code, at that point we can actually decide to make leukocyte poor, monocyte rich, or neutrophil rich based on how much red blood cells we are going to take to maximize the amount of the monocyte, lymphocyte, or neutrophil based on our intention. So as you can see, we are going to have three different bioformulation, and the Aspiradon is the only system so far gives us this ability, this flexibility to make different bioformulation, including the monocyte rich consistently. So let's check what we have in different bioformulation. You know, the leukocyte poor bioformulation is the safest one. We mostly focus on the platelet, and we're going to maximize the recovery of the platelet, but we prefer to keep the leukocytes as low as possible. Based on our system, you could get the platelet with 90%, around 90% recovery for the leukocyte poor bioformulation and keep the monocyte and lymphocyte around 30%. But the most important things, your neutrophil is going to be around 1% and less, and the red blood cells contents is going to be less than 0.08%, less than 0.1%. Which is very, very important, specifically when we are going to use the PRP for a neural tissue or the indications around the neural tissue. Another bioformulation is the monocyte rich, and we discussed we need to take a little of the red blood cells. We have the defined protocol for that. In this case, our platelet recovery is going to be over 90%, monocyte over 90%, lymphocyte over 80%, neutrophil around 10%. Still, it's going to be poor for neutrophil, and red blood cells around 1%. And the final bioformulation is going to be neutrophil-rich bioformulation with platelet, monocyte, lymphocyte over 90%, and neutrophil around 30%. So you could see the benefit of each of them. Leukocyte poor is the safest one. We could get mostly benefit from the platelet, but for monocyte rich and neutrophil rich, it's going to be the beyond of the platelets. It's not just the platelets. We actually get the benefit from the monocyte and lymphocyte in monocyte rich, mostly for immunomodulatory benefit from them. And with the neutrophil rich, the most benefit we can get from the neutrophil rich PRP is the angiogenesis in the case of regeneration. So for the case, actually, Dr. Ambach explained, let's connect this to the background introduction we explained to the lumbar pathology. There are many spinal problems that can cause nerve root compression, irritation, and inflammation. As depicted in the illustration, a herniated disc or bone spur can compress fragile spinal nerve roots in the neck or low back pain, low back. So when we consider injectables in the lumbar spine, we are not only thinking about the pain abstractly, we are thinking about the tight anatomical compartment and the surrounding tissue and cells. This is very, very important. The epidural space that Dr. Ambach showed the injection with it contains the dural sac, spinal nerves, blood vessels, connective tissue, and fat. In this case, most of the discomfort and pain is related to the neuroinflammation. PRP or other biologic injection aim to turn down the inflammatory cascade, reduce the swelling, and decrease the pain signaling. We have different bioformulation here. And also, based on the reports in the literature, we could also use the plated lysate and also corticosteroid. Which one is going to be the best one for us? Since we are going to modulate the inflammation, maybe monocyte rich. First of all, leukocyte is going to be the best option, safest option. What about monocyte rich? In this case, no. It's a little surprising. We are going to discuss why. Neutrophil rich at all. Plated lysate, maybe it's good, it's reported, but the difficulty about the plated lysate is the protocol and the consistency. If you don't follow the correct protocol, the consistency won't be as good as PRP. But it's the cell-free biologics, and mostly you're going to deliver the cocktail of the growth factor. Corticosteroid we don't recommend at all, since it's not a regenerative biologics. Here why we didn't consider the monocyte-rich PRP. Monocyte-rich PRP could be ideal one since we want to modulate the inflammation. But we have a big red flag when our target is the neural tissue and neuroinflammation. The big red flag is going to be the red blood cells. You remember when I explained the different bioformulation, I mentioned for monocyte-rich PRP and neutrophil-rich PRP, we have to take some red blood cells to maximize the recovery of the monocyte, lymphocyte, because some of them actually penetrated into the red blood cells layer. So it means we include the red blood cells. The problem is when we include the red blood cells, actually during the hemolysis, we are going to have free hemoglobin. And that free hemoglobin can produce for us hem. And the presence of the hem can actually activate a signal within the neural cells to produce some inflammasome and inflammatory cascade like NLRP3 inflammasome, and also increase the ROS in the mitochondria. Together, it increases the release of the pro-inflammatory cytokines like interleukin-1 beta and interleukin-18. And then it increases the neuroinflammation more and increase the pyroptosis, which is one of the inflammatory cell death. Okay, that's the problem. We cannot use the monocyte rich in this case, because in this case, specifically when we are dealing with the neuroinflammatory condition, nerve cells, the presence of the red blood cells is actually the red flag and toxic. Another indications, actually, Dr. Ambach treated was the facet joint, and also another one was SI joint. For both of them, the pathology of these joints are mostly cartilage degeneration and arthritis. Could be osteoarthritis, degeneration plus synovitis, capsular inflammation problem, and something like that. However, in most of these types of inflammatory environment, specifically for joints, we see the macrophage plays a role. The dominant macrophage is going to be the macrophage M1 or inflammatory macrophage, releasing mediators like TNF alpha, interleukin 1 beta, and matrix degrading enzymes that promote cartilage breakdown, joint inflammation, and bone remodeling. So what is our option for treatment? Different bioformulation of the PRP, concentrated protein, corticosteroid. Again, leukocyte-poor PRP is going to be the safest one. But for the joint inflammatory condition, since the dominant inflammatory cells are going to be the macrophage, monocyte-rich PRP could help a lot. Neutrophil rich, it doesn't help us, because for neutrophil rich, we can get mostly benefit of the angiogenesis. And in this case, we don't need angiogenesis. Okay, our target is the immunomodulation. Concentrated protein, we talked about this modalities and this biologic in our previous webinar, and you can reach out to our website and see the whole webinar. We talked about concentrated protein comprehensively. Corticosteroid, again, it's not our choice, and it's not the regenerative biologics. The important and vital precautions. When you are going to use the monocyte-rich PRP for inflammatory condition, you should be careful. It is perfect, except in the case of autoimmune disease or patient with systemic inflammatory disease. In this case, it doesn't work, and it could be worse. Why? Look at this distribution of the monocyte in our peripheral blood. In normal individual, in healthy individual, we have the monocyte in our body with this distribution, mostly classical monocyte, and around 90%, the rest are going to be non-classical and intermediate. Classical monocyte categorized as the non-inflammatory monocyte. But in the autoimmune cases, this portion, this percentage, this balance would be changed. Classical would be less, and non-classical intermediate percentage goes up. And actually, they change their phenotype in the peripheral blood, and they're going to be more inflammatory. But in the healthy individual with arthritis, not something like rheumatoid arthritis, something like osteoarthritis, we have this actually a distribution, mostly classical monocyte. And when we include the classical monocyte, actually the whole monocyte, but with this distribution within the PRP bioformulation, we actually increase the chance of polarization of the monocyte toward the M2 macrophage. In our inflammatory joint, mostly we have M1 macrophage, but when we include the monocyte in the PRP with the platelet, we increase the chance to change the polarization from the M1 toward the M2, which is the resolution macrophage, and we can resolve the inflammation. If you look at this cartoon, it shows us better. Even when we have the monocyte alongside with the platelet, some of the pro-inflammatory cytokines like interleukin 6 could be used as inducer or one of the non-inflammatory macrophage. So based on this, we can actually use the benefit of the macrophage monocyte to actually polarize the macrophage toward the M2 macrophage and modulate the inflammation. Another player is the lymphocyte, and when we enrich the macrophage monocyte in the PRP as a monocyte-rich PRP, we actually enrich the lymphocyte as well. In the healthy body, lymphocytes, which include T cells and B cells, make up a significant portion of the immune cells. T cells typically accounting for around 60 to 80% of the lymphocytes, and the regulatory T cells, Treg, gamma delta T cells, and T helper 2 are the cells, three main types of the lymphocytes in improving the tissue repair, and we can get the benefit from them. If you look at these different cartoons based on different studies for different tissues, you could see T cells, specifically Treg, could help to inhibit the macrophage M1 function or induce and support the macrophage M2 function. So when we enrich both monocyte and lymphocyte in the monocyte-rich PRP, we are going to increase first immunomodulation, and by using the benefit of the lymphocyte, we could increase the reparative properties of the PRP. There are different publications to support that. One of the first publication published 2021 to support in this way was when in that study they incubated monocyte-derived macrophage M1, inflammatory macrophage, with the PRP. They eventually saw that PRP suppressed the M1 macrophage polarization and promoted M2 macrophage polarization, which is supported, the hypothesized, actually we brought into 3 slides ago. The clinical study, we still don't have so many clinical study on that, but it's coming mostly and more in the literature. One of the clinical study actually is this. A single-arm open-label pilot study showed that patient knee pain and motor dysfunction were significantly attenuated after the polymononuclear cells therapy, which is the combination of the monocyte, lymphocyte, dendritic cells, and NK cells. Actually, we have all of them in the PRP when we make the monocyte-rich PRP. So, and when they followed by 1 year, they saw that significantly improved the outcome based on the VAS score and KUSA score. Another one is the study actually compared the polymononuclear cells compared to the hyaluronic acid, compared to the mixture of the PRP and hyaluronic acid. The result shows comparable outcome for all these 3 arms, and actually polymononuclear cells and PRP plus hyaluronic acid did better job than just hyaluronic acid. So when polymononuclear cells, lanolin, could give us this good outcome, why we don't want to combine that with the PRP and make the potent and strong and powerful bioformulation as monocyte-rich PRP. The last one is the preclinical study, and also in the knee osteoarthritis of the rat model supports the idea. As a conclusion, when we want to actually treat a patient, we need first ask the question, what is our goal from the PRP? Do we want to get the regenerative properties and function, or we are going to get the anti-inflammatory? And based on that, we could design and prepare our bioformulation. For neuroinflammatory targets, we should be very, very careful. Leukocyte pore is the safest one, not because of the leukocytes, because of the red blood cells in this case. When we inject intradiscal, we should be careful as well, because in the intradiscal case, also the problem, the concern is not the leukocyte. The concern is also the red blood cells. For arthritic joint, degenerative joint inflammation, and immunomodulation matters, we can get the benefit from the monocyte and lymphocyte with the monocyte-rich PRP bioformulation. Thank you so much for your consideration.
Right. Thank you so much, Dr. Farzaneh. It was very thorough. Thank you. So insightful. So now we've just completed both our presentations and we're in the question section of the webinar. So if anyone has any questions, feel free to submit them in the chat and our speakers will do their best to answer. To start off, I go over to Dr. Ambach and just kind of for beginners who are just starting off in the lumbar spine injection field, what are the most common mistakes that you think that they could avoid or things that little pitfalls that may pop up?
So I think especially for spine patients, I think the most common thing that we need to remember is to set patient expectations, especially for chronic spine pain, chronic low back pain. There's multiple pain generators. Sometimes there's psychosocial components that are involved. Patients come into you and they think that you're going to resolve their disc bulge. They think that you're going to regenerate their discs, and they think that you're going to get rid of their arthritis. And so you're going to have to set expectations with regards to what to expect from the treatment, how long will it last, when will they start seeing the effects. It's not immediate. You know, some of them will be calling you in 1 week and say, why am I not better? Um, and to tell them that it's probably going to be not not just a one session injection, especially for these patients who have multiple pain generators, wherein they might need boosters down the line in a year or two, or they might even need a series of injections. And so setting patient expectations for me is the main thing. And then obviously there's a lot of different factors, but that's just kind of one thing that you need to think of when you're talking to your patients and trying to formulate that plan in your head with regards to what biologic to inject.
Okay.
I think we lost our host here.
Yeah, let me continue that. So there is a question: is ultrasound guidance PRP injection an option rather than using
C-arm.
CR?
Yeah, so in leaner patients who's got a lower BMI, you can actually see their facet joints really nicely. You can do an intra-articular facet joint injection with ultrasound. You can do your supraspinal, interspinal ligaments. You can do your paraspinal muscle injections. You can do your SI joint injections, SI joint posterior ligamentous complex using ultrasound. You can also do a caudal epidural injection using ultrasound very easily. It's kind of hard to do a transforaminal epidural injection using an ultrasound. You just need that contrast to make sure that you're not vascular. Still the standard of care overall to use fluoroscopy, but there's definitely some pros to using ultrasound, especially in leaner patients. When patients are, have higher BMI, it's kind of hard to do ultrasound guided injections in the spine. Okay, so there's a question here with regards to Wharton's jelly. These are allogeneic treatments that's derived from birth tissue products. These are still illegal to use in the United States. And so I'm not aware if there's very limited studies on its use for the spine. And so these are not being used in the spine at this moment. Most of the biologics that are used on the spine is PRP and autologous MSCs, with the source being bone marrow concentrate. Even EmFat is very limited in the spine as well. There's one study of using SVF and and PRP in combination to the disc, but that's about it that I know. That are same-day injections. All the other studies are probably in the cultured cell category. Yeah, I mean, the most common injections that we do for the spine is the epidural injections, the facet injections, um, and SI joint injections. Entirely a presentation on its own is the intradiscal injections. And so that might be, a whole other topic to discuss, but it's really the main thing to formulate in your mind is the plan on which structures to inject. And then once you have listed out all the structures that you wanted to inject, then you have to determine your different PRP bioformulations. And that way you would know how much to do blood draw. You can set up the time and just kind of plan out that whole procedure time because it can be a little bit more complicated, especially with the spine.
Okay. There is another question. Is combination therapy with prolotherapy, corticosteroid, and PRP recommended?
So corticosteroids in combination with PRP, no. They're kind of doing two different things and they're counteracting the effects of each other. The only time that I do use very rarely steroids in the spine is if a patient comes in with a very, very hot radiculopathy, they have a life event that they need to get that relief right away. Although some would argue that you can still get an immediate relief with a leukocyte poor PRP or maybe a platelet lysate PRP with a really, really toned down version. And when I say toned down, more of the nanodose formulations of dexamethasone to kind of stimulate growth factors, but no role for steroids and PRP in combination. There are some practitioners that do a prolotherapy as a pre-treatment prior to the PRP injection, and that probably is more acceptable than using steroids.
What is the normal interval therapy in using PRP in the back? What is the most common retreatment?
Retreatment cycles. Yeah, so typically what I do is I do a functional spine unit approach. Because most of the patients don't really see the maximum benefit from these treatments until about maybe 3 to 4 months. Some of them will even be delayed up to 6 to 8 months. Usually I let them come back in about 3 months, 2 months, 3 months or so. And then if, depending on where they are at the time, then we can plan to do a repeat procedure at that time. Unless we are staging, the treatment options, I rarely do have them come, every week or every 2 weeks for a series of injections. I do have a hemocytometer on site, and so I know that if I have a good platelet dose, then these patients do well with just one session of multiple target injections.
Question about the charge.
This is very variable on number one, how many structures are you injecting? Is it, a one level? Is it a two level? Is it limited? Is it comprehensive? And then also, are you injecting the discs? Where in most of the cases for intradiscal injection, you're going to use a conscious sedation, which can add to your price. Are you doing it in your clinic? Are you doing it in a surgery center? Again, which will all add to the cost. But typically for a spine, let's say spine procedure, that's anywhere from a 3,000 to a 10,000 cost. It just really depends on how many injections and how many structures are you injecting and what kind of biologics you are injecting. We got Natalie back.
I'm so sorry, guys. A little bit of
It's
technical
okay.
difficulty there. Yeah, sorry about that. So we're a little bit over, but maybe one more question and then
Yeah.
we can continue. Okay. So I think I had a question about the approaches as far as when you're doing the injections. What are the factors that come into play when you're choosing between like a different approaches? Like, let me see, I'm not that familiar with the medical terms, but like the caudal versus I know all the others that you do.
Yeah,
And
yeah. So I
what
think
you
your question was what approach to do in an epidural injection.
exactly, yeah.
The two most, well, there's three approaches to do an epidural injection. Either you go transforaminally, wherein you inject through the openings on the side of the spine, or you do interlaminar injection, where you go central midline, or you go a caudal approach, wherein you go to the sacral hiatus. So the most common injection that's being used is a transforaminal approach because it gets you closer to the nerve roots. It gets you closer to the disc structures. It's more specific with regards to getting the biologic to the specific nerve root that you want to target, especially if it's a one-sided kind of radiculopathy symptoms. So those are the most common. That's the most common injection. The interlaminar is helpful for those patients who's got bilateral symptoms and they have a good, adequate spinal canal space into that posterior epidural space to perform the procedure. It's an easier injection to do because it's one injection versus multiple if you're doing transforaminal injection. And then you can also do your interspinal ligament injection at the same time. Caudal epidural is less sensitive. I call it the shotgun approach because you can cover as much structures as you can, usually up to the level of L5, maybe L4 with the caudal epidural. You have to inject higher volumes. And I usually use that when the patient's symptoms are more in the sacral level, kind of L5 level of symptomatology.
Okay, thank you so much. Oh, and we have a question from Ken Krusky. If you give a steroid injection and then you later choose to do a PRP injection, how much time do you allow?
Yeah, I typically allow 4 to 6 weeks in between. Some physicians are more conservative, do wait a whole 2 months before doing a biologic injection after a steroid injection. But I do 4 to 6 weeks.
Okay, thank you. So I think we can end there unless anyone has any last minute questions. Thank you everyone for your time. And if I could just grab 2 minutes just to go over some brief announcements, I will do so very quickly. Let me share my screen. Here we go. Um, let's see. Okay. All right. Can everyone see my screen?
Yes.
Yes.
Okay, great. So we have an upcoming event, Precision in Motion Conference. It's happening in May, and you can register through the Gulf Coast Biologics website. The topics that are going to be covered are adipose harvesting, bone marrow aspiration, nerve hydrodissection, spinal injections, and ultrasound guided injections. And the conference will be held at the Gulf Coast Biologics Training Center in Fort Myers. These are the panel of esteemed speakers and folks who are going to be doing the training. We have Michael Meng, and he'll be doing spine injection workshops. We have Sina Farzaneh, who you just heard from, and he's going to share more of his insights on formulations and mechanisms and all those underlying pathways that are mystery to most of us, but Sina's an expert in them. And then we have Dr. Miller, who will be telling us more about adipose harvesting. There's Dr. Rowan Paul for nerve hydrodissection, and Dr. Moses Irizarry Roman for BMA aspirations. So the conference is $1,500, and if you're an EmCyte product user, you get a discount, a substantial discount. It goes down to $950. Just call ahead before you register, and you'll get that discount. Another big plug, free ultrasound training, also at the Gulf Coast Biologics Training Center. Leslie Aja, diagnostic sonography specialist, does these, and you just register also through the Gulf Coast Biologics website and set up a training. And again, I should mention it's free, so no reason not to take part, to take advantage and get your free ultrasound training. And so EmCyte has an app. It's the Power Sales app, and it's fantastic. I have it on my phone. You use it to order. You can use it to file customer complaints. You can use it to do platelet yield calculations and platelet concentration factor calculations. It's very handy. You can use it to register also, I think, for free MSK training sessions. And also you can register at no cost to use the EmCyte data biologics. So it's very handy. There are other resources. Definitely worth downloading it and checking it out. And
think we lost you, Natalie.
Okay, we don't have Natalie. Fortunately, probably she has a problem with her laptop. Thank you so much all joining us for this session of Regenerative Edge. We are going to have our next one in about a month, so we will let you know about the next topic. Again, thank you for supporting us. You have a wonderful, wonderful evening, and thank you so much.
Thank you.
One thing before everyone goes, if you have questions on transitioning from pure PRP to a spiridome, let me know. I've had, I don't know, several hundred of them now, and it's a game changer technology as far as platelet yield. So just reach out to me. So
Perfect. Thank you so much.
have a good evening. Good job, Mary.
Thank you for joining us in this session of EmCyte's webinar series. Stay tuned for our next episode as we continue uncovering the science behind precision biologics.